Doctors, in this video we will be discussing about calculations of axis with a fundamental knowledge about vectors. Now, axis calculation has been a question of recent times, whereas vectors have been a question of past. So, 5 years, 6 years ago, many of questions coming from electrophysiology of heart tend to have vector based questions, mean cardiac vector, instantaneous vectors, but of late the focus has been shifted. They are not giving that much of importance to the fundamentals, vector cardiogram and vectors in the heart, and they straight away focus on cardiac axis, doctors. So, let us try to balance both these kinds of information. We will start from the vector with vector knowledge as a basics. Let us expand our information to axis. So, what is vector first? So, as you know, anything with a solid direction and a magnitude, we can call that as a vector, right. So, here in heart, current travel happens with a solid direction and a magnitude. Hence, we refer to electrical conduction in heart as a vector, right. So, if you consider the heart's orientation, doctors, if you consider heart's orientation, the natural anatomy of heart is primarily oriented towards left foot, isn't it? That is how heart is naturally been aligned. So, we have interventricular septum and the apex is slightly deviated to left, it is oriented towards left foot. Now, if you consider sinoatrial node and atrioventricular node, so we have two kinds of vectors first. The first one is a moment to moment vector, doctors. The first one is a moment to moment vector. The moment current starts getting generated from sinoatrial node, the current tries to flow towards left atrium. Current also tries to flow towards AV node through internodal pathway. Now, the current that has traveled to left atrium also through the intermyocytic gap junctions tries to reach AV node, right, doctors. So, if you look at the direction with which current is travelling and the magnitude at every single instant, there will be a different multitudinal directions and different multitudinal magnitude, doctors, right. At one instant current can be seen travelling towards left, at the next instant current can be seen travelling towards the AV node, from the superior aspect towards the inferior aspect. So, we have multi-directional, multi-magnitudinal current flow at every instant. Once AV node is reached, we know now AV node contributes to excitation of bundle of His, that goes to second part of the interventricular septum, third part of septum, as well as apex. Simultaneously, we have right bundle branch, excitation of left bundle branch. Now, when you consider left side, naturally, doctors, we know that left sided ventricle has got excess muscles, isn't it? Now, since there is more amount of muscle seen on left ventricle, more current naturally flows to left ventricle. So, how do we represent the increased current flow, right? We tend to draw that with a thicker arrow, just similar, right? So, if you consider the magnitude of left ventricular depolarization is comparatively thicker than right ventricle, isn't it, doctors? The right ventricular depolarization happens at a lesser magnitude, whereas left ventricular depolarization happens at a greater magnitude. Now, these kinds of vectors which can be recorded at every single instant of cardiac excitation, as the impulse start getting generated from SA node and as the time the impulse gets finished off with first part of interventricular septum, you can get multi-directional, multi-magnitudinal vectors. So, these such vectors are called as instantaneous cardiac vector, doctors. These vectors are called as instantaneous cardiac vectors. The nature of instantaneous cardiac vector is, number one, they have very different magnitudes. Left sided vectors will have greater magnitude compared with right sided vectors. Similarly, they have very different directions, okay. They have very different directions. Remember, instantaneous cardiac vectors, two properties, different magnitude, different direction. Now, what do I do is, I try to summate algebraically every single instantaneous vectors, right? It's all fundamental mathematics, isn't it, people? 6th standard algebra, 6th standard mathematics, right? Simple summation of multiple instantaneous vectors will contribute to a property called as mean cardiac vector. So, we take a algebraic summation of all these vectors that gives us a vector called as mean cardiac vector. Mean cardiac vector. Now remember, since mean cardiac vector is summated of multiple instantaneous vectors, they have a constant magnitude. They have a very constant magnitude and they have a constant direction. Constant magnitude and constant direction, doctors. Now remember, this one word mean cardiac vector has also been termed as axis. Mean cardiac vector is nothing but axis of heart. Mean cardiac vector is nothing but axis of heart, doctors. Now in order to find out in what axis heart electrical activity is happening, we use a separate diagram called as hexaxial reference system. We use a separate diagram called as hexaxial reference system. So let us have a quick look about what is hexaxial reference system and how it is getting constructed. Before that, doctors, I want you to pay close attention to this one point. Now always remember, when we speak about axis of heart, we are not referring or we are not indicating the anatomical position of heart to midline of body. Many people tend to think this way. Many students try to, many students have made this mistake, okay. When the word axis falls into their brain, they tend to imagine the anatomical position of heart with respect to midline of the body. You ask them what is normal cardiac axis, they will say plus 59 degree, and why it is plus 59 degree, they say this is midline of the body, heart is slightly present on the left side of the body and it is oriented towards left foot. So the angle with which the heart forms to the midline looks plus 59 degree. No, doctors, it is absolutely wrong. Whenever we speak about axis, we are referring to the direction with which current is travelling, that's it. We are not referring to the anatomical location of heart with respect to body's midline, not that way. We are simply referring to the direction with which current is travelling, doctors, okay. So what is hexaxial reference system and how we are using this system to calculate axis? Now we are going to take all the frontal plane leads. Remember, in order to construct a hexaxial reference system, we can't afford to use chest leads, okay. We have to use only frontal plane leads. Frontal plane leads, doctors. So what is frontal plane leads, right? Frontal plane leads, it is synonymously called as limb leads. Okay guys, so we know the limb leads, alright, lead 1, lead 2, lead 3, AVR, AVL and AVF. Okay, so let us take up a heart and let us get to know a quick revision of the position of, okay guys, so here, now if you consider constructing leads with the heart, okay, so we have right atrium here, left atrium, and apex of heart is oriented towards left foot. So we have lead 1 which is constructed between right arm and left arm, and we have lead 2 which is constructed between right arm and left foot, and lead 3 which is again constructed between left arm and left foot, doctors. Left arm and left foot. This is how leads are arranged. Now at the same time, we know very much that if you consider unipolar limb leads, lead that is exactly orienting towards right arm is AVR, exactly orienting towards left arm is AVL, and something orienting exactly towards left foot is AVF. So these are all the frontal plane leads. Now what I am asking is, I want you to take all the 3 bipolar limb leads first and connect it to one diagram, okay. So if you construct all these leads to one diagram, doctors, so you take this horizontal leads as such straight away, okay, you take this horizontal lead, doctor, you take the horizontal lead, just use it perfectly right, okay. So let me take up a horizontal lead and I am going to use it this way. So I am getting a horizontal limb lead. I am getting a horizontal limb lead that spans from 0 degree on one side and 180 degree on other side. Now we have a conventional understanding that whatever the axis that falls above the horizontal line has to be considered as a negative angle, and whatever the angle that falls below the horizontal line has to be considered as a positive angle. This is just a conventional understanding, doctors. This is no, this has got no physiological logic or explanation. We just use it as a conventional way for common understanding, right? So lead 1 is being represented as 0 degree on one side, 180 degree on other side. Now look at lead 2 here, right? If you see lead 2, guys, lead 2 is being constructed from right arm to left foot, and lead 3 is being constructed from left arm to left foot. If you use this angle, that is from right arm, okay, if you use the angle extending from right arm to left foot, you can use the very same angle here. Consider lead 2. Lead 2 can be constructed between, okay, lead 2 can be constructed between right arm and left foot, and lead 2 extends between plus 60 degree below the horizontal line and minus 120 degree above the horizontal line. Similarly, if you consider lead 3, doctor, if you consider lead 3, it is being connected from left arm and left foot. It has been connected between left arm and left foot. So you use the same orientation in the x-axial reference system. You have minus 60 degree to plus 120 degree. This is lead 3. So simply speaking, doctors, lead 2 and lead 3 are perfectly opposite, exactly opposite, right? If you consider lead 2 extends between minus 120 and plus 60, while lead 3 extends between minus 60 and plus 120. So first thing you got to understand this is 0, or we will start from the leads, okay. We have bipolar leads. We have bipolar leads with lead 1 extending from 0 and 180 degree, lead 2 extending from minus 120 plus 60, while lead 3 extends from minus 60 plus 120. You got to mug it up, right? Remember, lead 2 is minus 120, lead 2 is minus 120, while lead 3 is minus 60, and it is exactly opposite to the other numeric, doctors. Now, if you consider their corresponding perpendicular leads, lead 2 is exactly perpendicular to AVL. Lead 2 is exactly perpendicular to AVL, doctors, right? Unipolar limb lead with left arm as active electrode. It extends from minus 30 degree to plus 150 degree. It extends from minus 30 to plus 120 degree. Remember, lead 2 and AVL are perpendicular. Lead 2 and AVL are perpendicular. Lead 2 and AVL are perpendicular. Similarly, we have lead 1 and AVF as perpendiculars. Lead 1 and AVF as perpendiculars. Okay, we have lead 1, doctors, and AVF are perpendiculars. Lead 1 and AVF are exactly perpendicular. Similarly, we have AVR and lead 3. AVR and lead 3 are perpendicular to each other. Okay, so we have AVR and lead 3 perpendicular to each other. Okay, so AVR and lead 3 are perpendicular to each other. So if you consider all these x-axial reference system, we can able to summate this, that lead 1 is perpendicular to lead AVF, okay, then lead 2 is perpendicular to lead AVL, lead 3 is perpendicular to lead AVR, doctors. So this again you have to keep it up in mind. So I want you to memorize I want you to memorize these two tables, okay. Number 1, what lead is perpendicular to what lead, number 1. Number 2, the angles, doctors. Number 2, the angles. So, if you consider these angles, again it is very easy if you consider the angles, doctors, okay. So, let us extend our discussion to angle. Lead 1, as we saw, it is 0 to 180 degree. Its perpendicular lead AVF extends from minus 90 to plus 90 degree. Similarly, we have lead 2 extending from minus 120 degree to plus 60 degree, while lead AVL extends from minus 30 degree to plus 150 degree, minus 30 to plus 150 degrees. Similarly, we have the last two leads. Lead 3 is just exactly opposite, isn't it? Minus 60 degree to plus 120 degrees lead 3, lead AVR is minus 150 degree to plus 30 degrees. So, these values are very proportional, very corresponding, right. In one clue remember AVL and AVR, okay, AVL and AVR, doctors. AVL and AVR are correspondingly opposite. AVL and AVR are correspondingly opposite. While AVL spans from minus 30 to plus 120, AVR spans from minus 150 to plus 30 degree. Similarly, lead 2 and lead 3 are corresponding. It is minus 120 to plus 60, minus 60 to plus 120. So, always remember lead 2 and lead 3 are minus and plus opposite. AVR and AVL are minus and plus opposite, right. Lead 2, lead 3, 60, 120. AVR, AVL, 30, 150. That's it, doctors. So, ultimately you should have 180 degrees, that's it, okay. So, this is how these leads are being arranged with respective angles. Now, these two tables have to be in the back of your mind, doctors. There is no shortcuts, this itself is a shortcut. You have to memorize these values, there is no other way. If not, you cannot able to find access in your question, right. So, 5 years back, 6 years back, the questions on cardiac axis calculation were more or less simple. They will give you a straightforward ECG by simply looking at lead 1 and AVF, you can able to say very clearly that what axis it is, but not anymore. As things are getting complex and things are getting more and more deeper in concept as well as in applications, you have to be very sharp in axis calculation, doctors, because this is one very important topic in both physiology as well as in medicine. So, this is how hexaxial reference system is being designed, okay. So, in this hexaxial reference system, doctors, if you coming to calculation of axis, okay, if you coming to calculation of axis, as a general rule in a very simpler level, we will take it this way. So, this is lead 1 extends from 0 to 180 degree, and we have lead AVF extends from minus 90 degree to plus 90 degree, isn't it? Always the arrow indicates active electrode, okay. Now, this is the basic. We are using two leads, just two leads to calculate axis. Now, number 1 is lead AVF and lead 1, doctors, that's it. Mean cardiac vector, we know mean cardiac vector or cardiac axis. What is the normal mean cardiac vector or axis, doctors? It is plus 59 degrees. Now, this is called as mean cardiac axis. This mean cardiac axis has got a range, okay. The mean cardiac axis can range between minus 30 degree to plus 90 degree. This is the range of mean cardiac axis. Mean cardiac axis can range between minus 30 degree to plus 90 degrees. If the axis falls in this category, this axis is considered, the axis falls under this category, it's been considered as a normal axis. It's been considered as normal axis. At the same time, if the axis falls from minus 30 degree to minus 90 degree, the axis falls from minus 30 to minus 90 degree, doctors. If the axis falls at this range, this sector, we call the axis as left axis deviation. What is being represented as in green is normal axis. The one that extends from minus 30 to minus 90 is left axis deviation. At the same time, the axis that falls between 180 degree and plus 90 degree, the axis that falls between 180 and plus 90 degree, this is right axis deviation. So we have angle and axis for left axis deviation, angle and axis for right axis deviation, doctors. Similarly, if the axis falls between minus 90 and 180 degrees, if the axis falls between minus 90 and 180 degree, this is called as extreme axis. Extreme axis deviation, or also called as indeterminate. Indeterminate axis. Right, doctors, this is how basic cardiac axis can be determined by simply making the angle to, by simply looking at the angle and where it falls, in which sector of the hexaxial reference system the angle of mean cardiac vector falls. Based on that, we could be able to say what axis is it. Is it a normal axis, or is it a left axis deviation or right axis deviation, whatever it is, right. So remember, this is exactly what happens with if you use these two leads, okay people. If you use lead 1 and lead AVF, by looking at the quadrant at which the mean cardiac vector falls, we can able to say whether this is a normal axis or left axis deviation, right axis deviation, or extreme axis deviation, right, doctors. Okay, good. But is it sufficient? If you cannot able to use graphical papers and you can't able to measure an axis straight away, the next and best possible method is axis calculation in other way. If you have been given a series of ECGs, right, all you need to do is to find out isoelectric lead, doctors. Find out isoelectric lead, which means a lead which has got equal R wave and S wave amplitude. Lead which has got equal R wave and S wave amplitude. Okay, that's point number 1. Okay, in case if isoelectric lead is not seen, or in any of your 12 lead ECG you cannot able to find such a equiphasic R wave and S wave. Okay, if isoelectric lead is not found, find a lead with shortest QRS complex. If isoelectric lead is not found, find a ECG lead with very small, shortest QRS complex, as small as possible, which lead shows a very small QRS complex. Okay, point number 1. Okay, now once you are done, your second step is find an perpendicular lead. Find the perpendicular lead to isoelectric or small QRS lead, whatever it is. So once you have identified a lead with isoelectric QRS complex or short QRS complex, the second step you got to do is to find out the perpendicular lead for that one particular lead that you have just identified. Okay, say for example, doctors, for example, if lead 1 in your ECG shows isoelectric QRS, so you have normal duration of R wave, normal duration of S wave. Lead 1 is isoelectric lead. What is the perpendicular to lead 1? You know very well. Lead 1, the perpendicular lead is AVF. Good. So step 2 is AVF, doctors. You got to look at AVF. Now if AVF looks like this. Now in AVF, if you could see, the predominant morphology of AVF is positive. QRS is positive, right? AVF lead shows positive deflection primarily in QRS complex and S wave is very small. So, primarily speaking, AVF is positive. AVF is positive in morphology. AVF is positive in morphology, doctors. Okay. If AVF is positive in morphology, what does that tells you? Current is flowing towards the active electrode of AVF. That is it, isn't it? AVF lead shows upright deflection. What does that mean? Current is flowing towards the active electrode of AVF, isn't it? Now, what is the angle of AVF, doctors? AVF has been constructed between minus 90 degree and plus 90 degree. Okay, cool. So, what is the position of active electrode in AVF? We know very well AVF is the lead that looks at left foot, So, in hexaxial reference system, what is the left foot's position, doctors? See here, in hexaxial reference system, if you consider lead AVF, if you consider this one lead, so it is constructed between minus 90 degree to plus 90 degree and AVF is located to left foot, right? So, naturally the angle arrow should be oriented towards left foot. Now, active electrode is kept here towards the left foot and current is travelling towards active electrode, which is why you have a positive deflection, which means axis in this ECG is plus 90 degree. Axis of this ECG is plus 90 degree, doctors. Okay. So, that is how you got to decipher the axis. Since AVF shows positive morphology primarily, the axis is plus 90 degree. There was a question in recent year AIIMS straight away asking for cardiac axis. A ECG was given and we have been asked to find out the cardiac axis. This is the simplest way and most shortest way to calculate ECG axis, right? Remember, always find out isoelectric lead. If there is no isoelectric lead in your 12 lead ECG, go for the shortest QRS morphology lead. Okay, take that lead. Now consider the perpendicular lead. Okay, if it is lead 1, the perpendicular is AVF. If it is lead 2, the perpendicular is AVL. If it is lead 3, the perpendicular is AVR. Now look at the perpendicular lead. Determine whether QRS morphology is positive or negative. If QRS morphology is positive, it means current is going towards the active electrode of that particular lead. If it is AVL, active electrode is kept at left arm. If it is AVR, active electrode has to be kept at right arm. If it is lead 2, active electrode is at left foot. If it is lead 3, active electrode is again at left foot. So, by this way you could be able to decipher cardiac axis, doctors. So, if the question is not this complex and if the question is very simple, you have been given just 2 leads, lead 1 and AVF, that is all. You have been given just 2 leads, lead 1 is given, AVF is given. How to identify? Very simple, doctors. Look at the QRS morphology. If QRS morphology is positive, primarily it is both positive in lead 1. If QRS morphology is primarily positive in lead 1 and AVF, it is normal axis. If QRS is positive in lead 1 and negative in AVF, QRS is positive in lead 1, negative in AVF, it is left axis deviation. We know that, right? Lead 1, AVF. If both lead 1 and AVF are upright, QRS morphology of lead 1 and AVF are upright, this is normal axis. If lead 1 shows positive and AVF shows negative, both these fingers are leaving. So, this is L, left axis deviation. Okay. On the other hand, if AVF is upright and lead 1 is downright, these two fingers are touching each other. This is a good thing, this is a right thing. So, this is right axis deviation. Remember, lead 1 upright, lead AVF upright, normal axis. Lead 1 upright, AVF downright, they are leaving, left axis deviation. Lead 1 downright, AVF upright, this is right axis deviation. And if both are negative, doctors, if both AVF and lead 1 are negative, this is extreme axis deviation, also called as indeterminate axis. This is how we got to calculate axis in a ECG, doctors. That's it. So, we will take up one question to finish this topic. During which interval on ECG aortic valve closes? So, aortic valve closes, that is the question. What does aortic valve closure tells you? Closure of aortic valve indicates, this is nothing but second heart sound, right? This is nothing but end of systole and beginning of diastole. End of systole and beginning of diastole, isn't it? That is what is called as aortic valve closure. So, in this picture, if you consider, we just saw that QT interval, isn't it? So, this is Q wave, R, S and T. QT interval indicates complete ventricular event. QT interval indicates complete ventricular event. Okay, point number 1. Let us take up ventricular systole alone first, and then we will take up ventricular diastole, doctors. Okay. So, ventricular systole ranges between, it starts from onset of R wave and it goes till the end of T wave. So, from R wave till end of T wave, this is ventricular systole. At the end of T wave to next R wave, okay, doctors, at the end of T wave to next R wave, this faces ventricular diastole. So, as per the question, aortic valve closes, that is the question, right? Aortic valve closes, right? So, that tells us end of systole and beginning of diastole, okay, doctors, end of systole and beginning of diastole. Where the systole ends? At this segment, right? Segment E tells us the end of systole. So, answer is segment E, that is option D, doctors. That completes our ECG related topics. You have to be very familiar with few points. Always remember, axis is crucially important in ECG. T wave, mid myocardial cells, again very important topic in ECG. Q wave in ECGs. These three are extremely important, and QT interval when it gets applied to cardiology and medicine part of ECG, doctors. So, that completes our ECG basics as well as axis calculation.